Thank you all for inviting me to speak at your meeting today. As an obstetric physician, I always hope that maternal health can be optimized before pregnancy, and there is always room for opportunistic pregnancy planning, and this is where you all come in. I'm going to race through this presentation because there's a lot to cover, but I assure you all these notes will be available. I did send them through first. So pre-pregnancy counselling is increasingly necessary as older women with more comorbidities are now attempting pregnancy. And really, any time is a good time to discuss pregnancy for me. To provide a focus for today's topics, I've referred to the indirect or medical causes of maternal deaths in New Zealand. And these bars in orange represent the numbers. And as you can see, neurological disorders predominate, closely followed by cardiac and other causes. Hence, today's discussion will focus around epilepsy, rheumatic valvular heart disease, lupus, and then later on we'll discuss hypertension and thyroid disorders. Epilepsy is common, and SUDEP is common in the pregnant and postpartum intervals. Mortality from epilepsy is now higher than those of hypertensive diseases in pregnancy. A large part of this problem stems from the poor adherence to anti-epileptic drugs, or AEDs, and this is partly because of the perceived risks of teratogenicity. Despite the high rate of maternal deaths, those with epilepsy are seldom recognized as being high risk. Pseudo seizures, concurrent psychiatric disorders, social circumstances, illicit drug use, all these factors work against us recognizing this person as having a high-risk pregnancy. Now, fetal malformations in those with epilepsy have been a subject of huge debate. Epilepsy per se does not cause malformations, but it is the AEDs used to treat epilepsy and other conditions that are likely the cause. Of the AEDs used, valproate has the highest rate of malformations across all studies and populations that have been included. Valproate has an established role as being the bad person in pregnancy, but more recently, polytherapy with topiramate has also been shown to increase the risk of malformations. Please note that the numbers for topiramate use remain very small, and newer evidence does suggest that topiramates at 100 milligrams monotherapy, so the doses that may be used to treat other conditions, may potentially be safe. Now, it's not just congenital malformations, but also the neurocognitive effects of these AEDs. Again, valproate is the worst performing drug here. Folic acid use does partially attenuate these effects, hence the push to co-prescribe high-dose 5 milligram folic acid to all women on AEDs. In 2018, the Medicines and Healthcare Products Regulatory Agency in the UK effectively banned valproate use in females of childbearing ages unless there was no alternative agent and she was on a pregnancy prevention program. Now, I apologize for this very busy slide as it's literally hot off the press in JAMA of this year, actually. This tells us that topiramate monotherapy has been associated with neurodevelopmental issues with the autism spectrum disorder. The risk is more prominent when it is combined with other agents. Dual therapy with AEDs does increase the risk of neurodevelopmental issues in offspring, but this was not the case for levetiracetam and lamotrigine. As of July this year, the UK has initiated a large observational study on all pregnancies exposed to topiramate. And patients who can become pregnant on topiramate are counseled about the emerging risks and offered contraception. Now, there are many reasons for increased risk of seizures during pregnancy. Poor adherence remains the #1 contributor here. However, drug levels also fall with the dilutional effect of the increased circulating volumes and the more efficient renal clearance during pregnancy. This effect is more prominent with the newer AEDs such as lamotrigine and levetiracetam. As you can see, lamotrigine levels fall very early on in pregnancy. In the postpartum interval, when the plasma volumes contract and renal clearance returns to normal, this is when the drug levels rise again, and we need to rapidly titrate lamotrigine levels back to the pre-pregnancy doses, preferably within 2 weeks of delivery. In this UK-based study on therapeutic drug monitoring in pregnancy, they found that it was not superior to assessing the patients and adjusting AEDs. Now, there are caveats to this study. Firstly, the EMPOWER study predominantly recruited from dedicated epilepsy pregnancy clinics, which were run by neurologists or epilepsy nurse specialists. And from personal experience, I found that the patients in the UK were more likely to disclose a seizure, as a suspension of a driver's license for 12 months following a seizure had less dire consequences than if it happened in New Zealand. I tend to use therapeutic drug monitoring when clinical history and the presentation do not match, and I suspect there may be suboptimal adherence. However, if the person does report a seizure or increase in prodromal symptoms or triggers, then I would empirically increase the dose prior to a trough level of the AED. And trough levels are preferably done pre-morning dose. I find it useful to reiterate the precautions necessary for all persons with pregnancy, and in the postpartum interval, the risk of seizures is highest. The parturient should be forewarned that he or she will need to stay in hospital for at least 24 to 48 hours for close observation in a multi-bedded room. It's also a good time to remind the person about the precautions necessary for caring for their newborn. I used to be part of the epilepsy pregnancy clinic in the UK, and the same themes and problems that afflicted those with epilepsy are exactly the same here in New Zealand. Many of them are from the vulnerable spectrum of the socio-demographic. In some cultures, epilepsy is not accepted and the patients may not wish to disclose their seizures. This is particularly so in New Zealand, where there is a dependence on the capacity to drive. Other comorbidities are also more prevalent and a significant overlap with mental health issues. Many of these patients may have been diagnosed with epilepsy in childhood or at a time when the understanding around epilepsy and AEDs was less developed. And they often continue to have misconceptions around the safety of these AEDs and may try to discontinue these drugs without clinical oversight. Perhaps this needs to be discussed with all persons with epilepsy of childbearing ages, and swapping AEDs is probably best done under the guidance of a neurologist. And in those who have been told that they can come off their AEDs after a fixed seizure-free interval, pregnancy is not the best time to try this. Pre-pregnancy trough AED levels are useful, and most neurologists are now advocating co-prescribing of folic acid 5 milligrams. These are the resources. Remember that cardiovascular causes are the second most common cause of death in persons in New Zealand. And I will focus on maternal valvular heart disease. A quick reminder about the cardiovascular adaptations in pregnancy. You will find that our women tend to decompensate in the third trimester, typically around 28 to 32 weeks. Rheumatic valvular heart disease is common in New Zealand, but most regurgitating lesions are very well tolerated in pregnancy, especially if they have normal LV function. Stenotic lesions, in particular, the left-sided ones, are a little bit more tricky. These lesions inhibit the increase of cardiac output that accompanies the increasing plasma volume in pregnancy. And of course, those with previous endocarditis, metallic heart valves, and on warfarin are at particularly high risk. These are a few considerations in any young person considering pregnancy. Which valve, on warfarin or not? When was the last echo? Is the ventricular function normal? And what are the symptoms? Most heart failure medications are not compatible with pregnancy, and for that matter, neither is heart failure. So please ask about contraception. This is a modified risk score. Those in category 3 and 4 really shouldn't become pregnant, and everyone on this list should ideally have pre-pregnancy counseling before trying. Now, there are very few circumstances in which I say pregnancy is contraindicated, but in some groups, maternal mortality risk is so high that we just say, no, this is a terrible idea. Unfortunately, fertility is preserved despite cardiac problems, and contraception is essential. We would like to know about those with the following conditions, particularly if they're symptomatic prior to pregnancy. For those with metallic heart valves, swapping on to Clexane 1 milligram per kilogram twice per day based on her current weight, please. And many of them have other comorbidities as well, so they cause more problems in pregnancy for us too. And some resources for you. Now, I'm not sure if I have enough time for this, and I apologize if I run over. So patients with SLE are at greater risk of adverse pregnancy outcomes, and therefore ensuring that they remain on their pregnancy-friendly treatment is ideal. Poor pregnancy outcomes are more common in those with active disease at the start of pregnancy or 4 months prior to conception. This is particularly so if they have underlying disease damage from lupus nephritis or have secondary antiphospholipid syndrome. Now, when we utilized a Swedish population database to look at the rate of complications, we found that those with SLE had much higher rates of complications compared to the general population. Now, prednisone has always been touted as a pregnancy-friendly drug, and unless steroids are fluorinated, minimal amounts get across through to the baby. Nevertheless, high doses of prolonged steroids are detrimental to everyone, including the pregnant person. So if possible, inject intramuscular, intra-articular, and if oral doses need to be used, short courses please, but flares must be treated. I've divided up the commonly used anti-rheumatic drugs into early use during organogenesis and late use. And you'll find that some drugs that are contraindicated in embryogenesis can be used later on in pregnancy, such as mycophenolate mofetil and cyclophosphamide. Now, non-steroidal anti-inflammatories are not teratogenic, but need to be stopped after 32 weeks due to the reversible effects on the fetus's patent ductus arteriosus. Any female on teratogenic medications will need contraception, preferably long-acting. They will need to plan for their pregnancy when their disease is quiescent, and they need to be swapped to pregnancy-friendly medications. Most drugs are safe in pregnancy, and well-controlled disease is preferable to being drug-free. Most forms of contraception are safe in those with SLE, and despite SLE being a predominantly female disease, the combined pill or estrogen-containing contraceptives have not been known to cause flares of SLE in those with quiescent disease. However, contraindications for estrogen follow that of the general population, and in those with lupus, we would avoid them if they've had a history of thrombosis or have antiphospholipid antibodies. Now, if the patient has had a whoopsie-daisy and is already pregnant, as is usually the case in my pre-pregnancy clinic, I consider her medications, her disease control, and we try for rapid management of flares. Aspirin and calcium to attenuate the risk of placental insufficiency, which we will discuss later, and some baseline lab parameters are always helpful. Quantification of her blood pressure and other metabolic risks as well. Thank you. I apologize for the speed in which I did this.